primary aldosteronism, an update on the management. Dr. Manchi May Vivian. Queen Mary Hospital. Content background information and diagnostic algorithms. Localization and subtype differentiation. Management. Case scenario 60/M, good past health. Blood test confirmed primary aldosteronism. 17 mm right adrenal nodule. 7 mm left adrenal nodule. What should be the management? Adrenalectomy. Right adrenalectomy? Left adrenalectomy? Bilateral adrenalectomy? Medical therapy with aldosterone receptor antagonist. Background first described in 1954. Group of disorders in which aldosterone production is inappropriately high, relatively autonomous, and non-suppressible by sodium loading. 1. Estimated prevalence of 11.2% in hypertensives. 2. Hypokalemia not always present. 52% aldosterone-producing adenoma. 83.1% bilateral adrenal hyperplasia. Jerome W. Connecticut, 1907 to 1994. Dr. Jerome W. Connecticut, American endocrinologist, presented his index patient in the clinical research meeting in 1954. 1 Jacqueline Endocrinology 93 to 3266 to 3281, 2008. 2 Rossi et al. Jack Volume 48, Number 11, 2006, 2293 to 300. Types of primary aldosteronism. Approximate prevalence %. Aldosterone-producing adenoma. 30. Bilateral idiopathic hyperaldosteronism. 65. Primary adrenal hyperplasia. Less than 2. Aldosterone-producing adrenocortical carcinoma. 1. Aldosterone-producing ovarian tumor. Less than 1. Familial hyperaldosteronism. Role for adrenal venous sampling in primary aldosteronism. Young W.F. et al. Surgery. December 2004. Diagnosis of primary aldosteronism. Screening. Aldosterone/renin ratio, ARR. Plasma aldosterone concentration, PAC. Elevated ARR greater than 20 nanograms/dL per nanogram/ml/H and PAC greater than 10 nanograms/dL. Confirmation. Intravenous saline load/oral salt load. Captopril challenge test. Fludrocortisone suppression test. Screening test. SI unit mol/LX 27.7, mol/L per minute x 12.8 equals 550 mol/L per nanogram/ml/H. No standard cutoff value. Higher cutoff results in higher false negative values. Can be influenced by most antihypertensive drug therapy. Diagnostic test. Collaboration with endocrinologists. No consensus on the optimal test. Lateralization and subtype differentiation. Computed tomography, CT. Adrenal scintigraphy. Adrenal venous sampling, AVS. Computed tomography. Young W.F. et al. The incidentally discovered adrenal mass. New England Journal of Medicine 2007, 356, 601-10. Adrenocortical carcinoma, adrenocortical adenoma. Young W.F. et al. The incidentally discovered adrenal mass. New England Journal of Medicine 2007, 356, 601-10. Lateralization and subtype differentiation. Computed tomography, CT. Adrenal scintigraphy. Adrenal vein sampling, AVS. Adrenal scintigraphy provides functional information. 131I6-beta-iodomethylnineteen-norcholesterol, NP59. Marker of adrenocortical uptake. Resolution problem. Previous study suggested that the detection rate was related to adenoma size. It failed to detect adenoma size less than 1 cm. Huang et al. Role of 131INP59 adrenal imaging in patients of ACT-independent Cushing's syndrome. UCL MedSci 2001 *14:75-83. Chen YC et al. Use of NP59 SPECT/CT imaging in atypical primary aldosteronism. QJ Med, 2013. Lateralization and subtype differentiation. Computed tomography, CT. Adrenal scintigraphy. Adrenal venous sampling, AVS. Adrenal vein sampling. First proposed in 1967 as a test to distinguish between aldosterone-producing adenoma and idiopathic hyperaldosteronism. Gold standard for lateralization of disease. Femoral venous access. Simultaneously left and right adrenal venous sampling. Blood aldosterone and cortisol level. Conicel et al. Adrenal vein sampling. Techniques in vascular and interventional radiology 13, 110-125. Interpretation confirmation of correct position of adrenal catheters. Cortisol level from adrenal catheters being 5 to 10 times the value obtained from peripheral sheath. Asymmetrical aldosterone, cortisol values on the affected side being 3 to 5 times the value obtained from the unaffected side. Conicel et al. Adrenal vein sampling. Techniques in vascular and interventional radiology 13, 110-125. Left adrenal vein catheterization. Right adrenal vein catheterization. Conicel et al. Adrenal vein sampling. Techniques in vascular and interventional radiology 13, 110-125. Lau J.H.G. et al. Clinical Endocrinology, 2010, 76, 182-188. Diagnostic values and accuracy. 203 patients were selected for AVS from 1990 to 2003. 194 patients underwent successful adrenal vein cannulation. Success rate 95.6%. Computed tomography, AVS and histopathological findings were compared. Young W.F. et al. Role of adrenal venous sampling in primary aldosteronism. Surgery 2004, 136, 1227-35. Discordant between CT and AVS. 110 patients, 56.7%, had unilateral source for aldosterone hypersecretion. Normal CT scan. 24. Bilateral micronodule. 16. Bilateral macronodule. 2. Unilateral micronodule. 731 contralateral gland. Unilateral macronodule. 122 contralateral gland. Combination of micronodule and macronodule. 1118 macronodule. 418 micronodule. Young W.F. et al. Role of adrenal venous sampling in primary aldosteronism. Surgery 2004, 136, 1227-35. Discordant between CT and AVS. 21.7%, 42 patients, would have been incorrectly excluded as candidates for adrenalectomy. 24.7%, 48 patients, might have unnecessary or inappropriate adrenalectomy. Young W.F. et al. Role of adrenal venous sampling in primary aldosteronism. Surgery 2004, 136, 1227-35. Discordant between CT, MRI and AVS. Systematic review of 38 studies, 950 patients included. 37.8% discordance between CT MRI and AVS. 14.6% inappropriate adrenalectomy. 19.1% inappropriate exclusion from adrenalectomy. 3.9% adrenalectomy on wrong side. Campersum J.E. et al. Systematic review, diagnostic procedures to differentiate unilateral from bilateral adrenal abnormality and primary aldosteronism. Annals of Internal Medicine, 09-2009, Volume 151, Issue 5, pages 329-337, Adrenal venous sampling NP59 adrenal scintigraphy. Computed tomography. Adrenal venous sampling. NP59 adrenal scintigraphy. Easily available. Technically demanding. Expertise required. Requirement of radio-labeled material. 3 to 5 day test. Non-invasive. Invasive. Complication rate 2.5%. 3. Good resolution. Limited spatial resolution. Improved with NP59 SPECT/CT. Sensitivity 77%. 1. Specificity 80%. 1. Accuracy improved if discrete unilateral macronodule. Sensitivity 95%. 4. Specificity 100%. 4. Planar scintigraphy sensitivity as low as 40%. 2. Sensitivity increased to 81.8% when combined with CT2. Lau J.H.G. et al. Clinical Endocrinology, 2010, 76, 182-188. Yen R.F. et al. The Journal of Nuclear Medicine, 2009, 50, 10, 1631-1637. Young W.F. et al. Surgery, 2004, 136, 6, 1227-1234. Tsais et al. Formos J. Endocrine Metab 2011, 22, 38-43. Conicel et al. Adrenal vein sampling. Conicel et al. Adrenal vein sampling. Techniques in Vascular and Interventional Radiology 13, 110-125. Management bilateral idiopathic hyperaldosteronism. Medical treatment, aldosterone receptor antagonist. Intolerance/refractory cases, bilateral adrenalectomy. Aldosterone-producing adenoma. Primary adrenal hyperplasia. Adrenalectomy, laparoscopic/open. Emerging therapies. Acetic acid injection. Radiofrequency ablation. Moutier et al. Prediction of successful outcome in patients with primary aldosteronism. Current treatment options in oncology, 2007, 8-314-321. Back to our patient adrenal to peripheral cortisol level. Right side, 3.6 versus left side, 3.2. Lateralization index 7.4. Right side, 42 versus left side, 5.7. Right adrenalectomy performed and Connecticut's adenoma confirmed. Improvement in ARR 1 month after operation. Conclusion. Primary aldosteronism is frequently underdiagnosed in hypertensives. Aldosterone-producing adenoma and bilateral idiopathic hyperaldosteronism are two commonest causes of primary aldosteronism. Lateralization is important for identification of surgically amendable causes. Reference. Gallant E.S.J. et al. Primary aldosteronism, Emerging Trends. Trends in Endocrinology and Metabolism. September 2013, Volume 24, Number 9. Role for adrenal venous sampling in primary aldosteronism. Young W.F. et al. Surgery. December 2004. Schwartz et al. Screening for primary aldosteronism in essential hypertension. Diagnostic accuracy of the ratio of plasma aldosterone concentration to plasma renin activity. Clinical chemistry. 51-2. 386-394. Young W.F. et al. The Incidentally Discovered Adrenal Mass. New England Journal of Medicine 2007, 356, 601-10. Khan S.L. et al. Adrenal Vein Sampling. Techniques in Vascular and Interventional Radiology 13, 110-125. Huang Yi et al. Role of 131-INP59 adrenal imaging in patients of ACT-independent Cushing's syndrome. UCL MedSci 2001 14:75-83. Chen Y.C. et al. Use of NP59 SPECT/CT imaging in atypical primary aldosteronism. QJ Med, 2013. Rossi G.P. et al. A prospective study of the prevalence of primary aldosteronism in 1125 hypertensive patients. JACC Volume 48, Number 11, 2006. Moutier et al. Prediction of successful outcome in patients with primary aldosteronism. Current treatment options in oncology, 2007, 8-314-321. Stoicer M. et al. Update in primary aldosteronism. Jacqueline Endocrinolomatab, 2009, 94, 3623-3630. Lucy et al. Radiofrequency ablation for benign aldosterone-producing adenoma, a scarless technique to annul disease. Annals of Surgery 256 6, 1058-1064. Campersum J.E. et al. Systematic Review, Diagnostic Procedures to Differentiate Unilateral from Bilateral Adrenal Abnormality in Primary Aldosteronism. Annals of Internal Medicine, 09-2009, Volume 151, Issue 5, pages 329-337. American Association of Clinical Endocrinologists and American Association of Endocrine Surgeons Medical Guidelines for the Management of Adrenal Incidentalomas. The Endocrine Society's Clinical Guidelines. Jacqueline Endocrinolomatab 93, 3266-3281, 2008. Thank you. Questions? Who should be screened? Moderate to severe hypertension. Resistant hypertension. Hypertension with a family history of early onset disease. Hypertension with an adrenal incidentaloma. History of cerebrovascular accident occurring before age 40 years. First degree relative with primary aldosteronism. Galante S.J. et al. Primary aldosteronism, Emerging Trends. Trends in Endocrinology and Metabolism. September 2013, Volume 24, Number 9. Sequelae of Primary Aldosteronism. Galante S.J. et al. Primary Aldosteronism, Emerging Trends. Trends in Endocrinology and Metabolism. September 2013, Volume 24, Number 9. Protocol Interpretation Intravenous Saline Load. Infusion of 2 liters of 0.9% normal saline over 2 hours. In recumbent position. Pack greater than 10 nanograms/dLs post-infusion is highly suggestive of PA. Oral salt load. Sodium intake greater than 6 grams/day for 3 days with diet and sodium chloride tabs. 24-hour urinary aldosterone excretion greater than 12 micrograms/day consistent with PA. Captopril challenge test. 25 to 50 mg oral captopril after sitting or standing for 1 hour. ARR greater than 30 to 50. PAC remained elevated, greater than 8.5 nanograms/dL or greater. Renin remained suppressed. Fludrocortisone suppression test. 0.1 mg of fludrocortisone every 6 hours for 4 days. PAC greater than 6 nanograms/dl confirms PA. Renin suppressed to less than 1 nanogram per milliliter/H. Cortisol measured 10 am lower than measured 7 to 8 am. Galante S.J. et al. Primary Aldosteronism, Emerging Trends. Trends in Endocrinology and Metabolism. September 2013, Volume 24, Number 9.